Thank you for the introduction and also for the invitation to speak today. I'm really excited to be here to talk about our research to you. So, as the other speakers today have discussed, cravings for cigarettes can be a serious impediment to relapse. They're a very important component of addiction, and successful cessation requires smokers to repeatedly choose not to smoke despite strong cravings for cigarettes and a deeply ingrained habit of smoking. The decision to smoke or not to smoke can be modeled as an interaction between self-control and the reward and habit-driven cravings and impulses. In the brain, neural executive control systems contribute to behavioral self-control by maintaining a focus on goal-driven behavior. So the neural executive control network can be engaged to provide top-down control to down-regulate the reward and affective processes that drive craving and promote immediately rewarding behavior such as smoking. When you have a stronger executive control system, decision-making favors goal-oriented behavior, but when executive control is weaker, the balance shifts in favor of immediately rewarding behavior and an individual is more likely to relapse. Unfortunately, nicotine withdrawal is associated with deficits in executive function and reduced activation in brain regions that are essential to the executive control network, such as the dorsolateral prefrontal cortex, or DLPFC. This means that smokers are experiencing deficits in control right when they need it the most during a quit attempt. And our lab has found that reduced activation in the DLPFC actually predicts smoking relapse. So our hypothesis was that if we can find a treatment that can enhance cognitive control during abstinence, we can give people a better chance to be successful in their smoking cessation. Okay. So we turned to the literature, and one of the treatments that jumped out to us was a brain stimulation method called Transcranial Direct Current Stimulation, or tDCS. tDCS is a type of non-invasive brain stimulation in which light electrical currents are applied to the scalp, typically by way of a pair of electrodes covered in saline-soaked sponges. It's thought that neural activation is enhanced under the anode and suppressed under the cathode. A single session of tDCS was shown to improve cognitive performance and reduce impulsivity in healthy subjects, and these effects persist beyond the end of active stimulation, possibly due to effects on long-term potentiation. In smokers, initial research was very promising. It showed that targeting executive control with tDCS could potentially be beneficial for smoking cessation. So tDCS applied over the DLPFC was shown to acutely reduce cue-induced cravings, and repeated sessions also reduced self-reported smoking rates, even in smokers who weren't actively trying to quit at the time. However, other studies have found no effects on craving, or they found that changes in craving did not transfer to changes in smoking rates. And there are several reasons this could be. Mostly it's related, I think, to differences in study design. There's a good bit of variation in the literature in terms of design factors, such as electrode placement, the number of sessions, and the timing of administration, concurrent training tasks that they use, and these factors can all contribute to tDCS outcomes. So we decided to test whether tDCS, targeting the executive control system during abstinence, could enhance control and help smokers exert greater control over their smoking behavior. Our hypothesis was that active anodal tDCS applied over the left DLPFC would increase their ability to resist smoking while they were abstinent. And to test this, we used a validated smoking lapse paradigm designed by Sherry McKee at Yale University. Our first study was a pilot study, and in this study, participants first completed an eligibility session and then completed 2 in-person sessions in a within-subject design separated by a 2-week washout period to reduce potential carryover effects. Each session was identical, except that at one session they received active stimulation, and at the other session they received sham stimulation. And the order of sessions was double-blind and counterbalanced. At each session, we required them to be abstinent overnight prior to the session, and we biochemically confirmed that using exhaled carbon monoxide readings at the start of the session. They received 20 minutes of stimulation, active or sham, at the start of the smoking lapse paradigm, which itself was about 2 hours long in total. So as I mentioned, the smoking lapse paradigm that we used was designed and validated by Sherry McKee at Yale University, and she was gracious enough to help us adapt it for co-administration of tDCS. So in this paradigm, participants are seated in one of our dedicated smoking labs. They have a pack of their preferred brand of cigarettes, a lighter, and an ashtray in front of them as smoking cues. And the paradigm is divided into two periods, a resist period and an ad libitum smoking period. First is the resist period. So they're instructed that they'll be in this room for the next 50 minutes, and they can begin smoking whenever they like, but we ask them to try not to smoke. For every 5 minutes that they're able to successfully resist smoking, they'll earn $1, up to a maximum of $10 if they make it the whole 50 minutes. We give them magazines to read from which we've removed any smoking cues, or they're allowed to bring their own reading materials, but we ask them not to use their phones and not to eat or drink anything other than water during this period. So at the end of the resist period, we go in, we remove the tDCS equipment, and we give them new instructions. We tell them we're giving them 8 cigarettes, and they have a $4 tab with the researchers. For the next hour, they have to stay in the room, but they can smoke as many or as few of the cigarettes as they like. For every cigarette that they smoke, we remove 50 cents from their $4 tab, and they get to keep any money that's remaining at the end of the session. So the primary outcomes for this paradigm are latency to the first cigarette, as well as the total number of cigarettes smoked. And these outcomes have been shown to correlate with measures of nicotine dependence and craving. And most importantly, they're sensitive to medication effects. Effective smoking medications such as varenicline and bupropion increase latency to smoke using this paradigm. So for the tDCS, we use the International 1020 system for EEG to locate the left DLPFC. We place it over the F3 location. And we place the cathode over the right supraorbital area. And remember, our intent is that activation is enhanced under the anode. So the equipment is put into place before the resist period starts, and we left it there to the end of the resist period so that we wouldn't interfere with their smoking behavior by interrupting them. But the stimulation only lasted for 20 minutes in total. During the active session, stimulation is ramped up to 1 milliamp over 30 seconds, held constant for 19 minutes, and then ramped down over 30 seconds. But for the sham stimulation, we ramp the stimulation up to 1 milliamp over 30 seconds, and then immediately ramp it back down at the beginning and the end of the session. And this procedure mimics the skin sensations that are associated with active stimulation, but is not sufficient to induce persistent effects in the brain. Most participants are unable to distinguish between active and sham procedures using this process. So participants in this study were healthy adults between the ages of 18 and 60 who reported smoking at least 10 cigarettes per day for at least the past year. We excluded anyone who reported a history of axis 1 psychiatric disorders other than nicotine dependence, anyone who is currently using nicotine replacement therapy, or anyone who had a contraindication for tDCS, such as a metal plate or an opening in their skull. We had a final sample of 25 people. They were on average about 42 years old. Most were male and African American. The average number of cigarettes smoked each day was about 15, and they were moderately dependent according to the Fagerström test for nicotine dependence. So in order to analyze the data, we measured latency to smoke across the entire session. And if someone didn't smoke during either period, we set their latency to 110 minutes, or the total time of the resist and the ad-lib period combined. We used multiple regression modeling, controlling for age and sex, as well as nicotine dependence and pre-session urge to smoke for negative reinforcement, or the brief questionnaire on smoking urges factor 2, because these measures were previously shown to predict latency to smoke in this paradigm. We also controlled for session order, whether they had received their active session first or their sham session first, but there were no order effects on the outcomes. What we found was that the active stimulation significantly increased latency to smoke by about 9 minutes and decreased the total number of cigarettes smoked by about 1/4 of a cigarette. To assess safety and tolerability, we asked participants to rate the degree to which they experienced 10 possible side effects of tDCS using a scale of 0 or not at all to 10 or severe. Side effects were generally mild, rated as less than 3 out of 10, except for some moderate tingling and itching at the site of the electrodes. None of our participants asked to discontinue the stimulation. And unfortunately for this one, because we didn't want to draw attention to potential differences between these sessions, we asked them at the end of the second session to rate their experience over the entire study, and we were not able to directly compare the 2 sessions. However, none of the participants were able to guess accurately which session was active and which session was sham at a rate greater than chance. So from this pilot study, we concluded that active anodal stimulation applied over the left DL-PFC could indeed increase latency to smoke using this paradigm, and it reduced the number of cigarettes smoked. Stimulation was well tolerated by the participants. However, the effects were relatively small, only about a 9-minute increase in latency. And for comparison, varenicline produces about a 20-minute increase in latency using this paradigm. It was also only a single session of tDCS, and we observed smoking behavior for a short period of time afterwards. And then finally, we weren't actually able to assess the acute effects on craving because post-session craving ratings would have been confounded by whether or not a participant chose to smoke during the session. So this led us to several questions that we felt would be important to address in the next study. First off, would a higher dose of tDCS provide larger effects? The literature is inconclusive on the dose-response effect of tDCS. So we also wondered whether multiple stimulation sessions could provide a cumulative effect, and very importantly, do the effects persist beyond the end of the stimulation session? We designed a larger proof of concept study to try to address these questions. The eligibility requirements for this study were very similar to our pilot study, except for this one, we also asked the participants be highly motivated to smoke. We asked them whether they were interested in quitting smoking, and then going down a list of, are you interested in the next 6 months, in the next 3 months, in the next 1 month? And we excluded anyone who was not interested in quitting smoking in the next 3 months, based on data that highly motivated smokers respond differently in medication paradigms. So after they completed the eligibility session, they were randomized to one of 3 dose groups: active 1 milliamp, active 2 milliamp, or sham stimulation. Each dose group completed identical procedures. They completed 3 laboratory sessions on days 1, 3, and 5 of the study. During the laboratory sessions, they received 20 minutes of their assigned tDCS dose in the context of the smoking lapse paradigm. And then at the end of the 3rd session, we gave them a brief smoking cessation counseling session. And we asked them to undergo a 7-day monitored abstinence period that we framed as a practice quit attempt. So we asked them to stop smoking at 10 p.m. on the evening of day 5, and then come in for visits every other day during the monitored abstinence period on days 6, 8, 10, and 12 to provide exhaled carbon monoxide readings so that we could biochemically confirm their smoking status. As an additional incentive, we offered them $15 per day of confirmed abstinence in order to, just motivate them to try their best to not smoke. So this 7-day practice quit attempt has been a validated medication screening paradigm, and the primary outcome for this paradigm is the total number of days of confirmed abstinence during the period. Also, number of days of confirmed abstinence during the first week of a quit attempt has been shown to significantly correlate with 6-month smoking cessation outcomes, so we felt this would be a good screening measure of efficacy for tDCS. So our participants in this study were very similar to our pilot study in terms of demographics. We performed a planned interim analysis when we reached about 35 participants per group. There were a total of 106 here. On average, they were about 45 years old, again, mostly male, mostly African American, generally well educated, having completed at least some college. They smoked about 15 to 16 cigarettes per day, and again, were moderately dependent. Unfortunately, when we went to look at our primary outcome of total days of abstinence during the quit week, there was no indication of a dose effect of tDCS on the outcome, even after we controlled for age, sex, and nicotine dependence. So we thought to ourselves, well, maybe tDCS doesn't help people quit smoking completely, but maybe it helps them at least reduce the number of cigarettes that they smoke during this time. We then looked at the change in average number of cigarettes per day compared to their baseline smoking rate reported at the eligibility session. But again, there's no evidence for any dose effect on this measure as well. So next we looked at our laboratory outcomes to see if we had at least replicated our original finding. But as you can see here, there's no evidence that there's a dose effect of tDCS. There's no effect of average if we lump 1 milliamp and 2 milliamp together versus sham, and there's no evidence for a cumulative effect of tDCS on either of these outcomes. And so finally, we tried to evaluate the effects of tDCS on cravings. And as with our pilot study, we couldn't evaluate acute effects of tDCS. So what we did is we compared pre-session urge to smoke, which was assessed at the beginning of each session before anyone had smoked any cigarettes. So we subtracted ratings at session 1 before anyone had received any tDCS from ratings at session 3 after they'd received at least 2 sessions of their assigned dose. And as you can see here again, there's not a very strong evidence for an effect on craving. So based on the results of our interim analysis, we performed a futility analysis based on conditional power. And so conditional power assumes that, or conditional power is the probability of rejecting the null hypothesis, assuming that you have the data that you've already collected, and any data that you haven't collected yet would follow your original assumed effect size. The typical cutoff for conditional power in a clinical trial is 0.2. So assuming if you have less than a 20% chance of rejecting the null hypothesis, it's not worthwhile to continue and to invest the effort. Conditional power for our study was 0.13. And so unfortunately, we have discontinued recruitment for this study. And these results do not support further development of this particular tDCS approach as a smoking cessation treatment. So obviously, this was a disappointing result for us, but there are a couple of factors that might have contributed to these outcomes. First would be the timing of our tDCS administration. So we chose to administer tDCS during the smoking lapse paradigm when all participants were abstinent, because we specifically wanted to test whether tDCS could enhance cognitive control during abstinence. However, there is some evidence that nicotine withdrawal impairs tDCS-induced neuroplasticity, which may have limited our ability to observe persistent effects in this study. So any future studies that wish to test tDCS might want to use a training task that does not require abstinence as a precondition. Second, it's possible that 3 sessions is not a sufficient dose in order to induce durable and tangible effects on neuroplasticity. Studies of tDCS for depression have typically found better results using longer treatment protocols with 5 to 10 treatment sessions. However, there have been a couple of studies of tDCS for smoking cessation that have used longer treatment protocols, and the outcomes have been mixed, so I think the jury's still out on that one. In terms of future directions, I think that more research on the factors that influence tDCS, such as the number of sessions required, the timing of the sessions, the concurrent tasks used, or the electrode placement would really be beneficial for the field as a whole. It's also possible that other neurostimulation techniques, such as transcranial magnetic stimulation, might have the potential to produce a more reliable effect since they don't require active participant engagement with the system. So in conclusion, I'd like to thank our team at the Center for Interdisciplinary Research on Nicotine Addiction, in particular our principal investigator, Karen Lerman, who led the research. Special thanks also to Dr. Roy Hamilton's lab for teaching us to use tDCS, and to Dr. Sherry McKee for helping us adapt her protocol for tDCS co-administration. And with that, I'd be happy to take your questions.
A question from Dave.
I understand that you were using milliamps as your independent manipulation. However, I'm wondering how much is actually going through the skull into the brain as opposed to across the skull through the scalp, and if you control for, like if you had someone with highly conductive gel or something in their hair, you're going to have the current going that way, not into the brain at all. I also know that African Americans tend, as a group, to have much higher skin resistance, which would make it also go lateral rather than through into the skull. So you have any independent evidence with the equipment as you used it, that it's really getting into the skull? So
yeah, that's a really important question for tDCS research. There is a lot of inter-individual variability, and there are some really nice papers out there showing theoretical models for distribution of current throughout the brain. And it's important to remember with tDCS, it is not a precise treatment. The effects of tDCS are very diffuse and very dependent on where you place the electrodes. So it's also, as you said, it's dependent on the individual's physiology. So, a thicker or thinner skull, more or less, muscle to fat ratio. These can all affect how much current is actually getting into the brain. Unfortunately, I don't know of a way yet to predict that beforehand. But it is something that I know that there's some active research going on.
Hi. Before you guys quit altogether, you might try homogenizing your sample by looking at smokers with ADHD, because they're very well known to have executive dysfunction. And there's a lot of literature on that.
Yeah.
So by homogenizing on them and doing whatever other maneuvers you're going to take to increase your signal strength, you might get better result.
Yeah, and that's a good point. It's possible that there's a subpopulation of smokers who experience greater cognitive deficits, such as those with ADHD. I don't know that we measured we excluded anyone with Axis 1 psychiatric disorders from this study, but we have recently published a paper where we looked at tDCS as a treatment for ADHD specifically, independent of smoking status. Then there were only 3 smokers in that group, though, so it wasn't possible to look at them as a subpopulation. We did find some positive effects of tDCS for we used the Conners Continuous Performance Task, and we were able to affect commission errors with tDCS treatment in ADHD population. So, yeah.
Just a curiosity. Do you reduce the impedance somehow with a braid so you
So we
the
do.
electrode so it could have a chance of getting through the skull more easily as opposed to?
We do clean the participant's skin beforehand with an alcohol wipe to try to get any surface oils or makeup or hair gel out of the way. And we use saturated saline-soaked sponges to try to increase, the electrical conductance as much as we can. We have, on the tDCS advice, there is a measure of impedance, and it automatically shuts off if it gets too high. But typically, participants will let you know if the impedance is too high because it becomes unpleasant for them. And so we tend to monitor participants while they're receiving tDCS. In our pilot study, nobody asked to withdraw. In our proof of concept study, we did have 2 people who asked to stop the stimulation early because it was too uncomfortable for them. But I believe that was in the 2 milliamp group, so it's a little bit stronger. But it gets a little bit warm, red, mostly itching and like a prickling sensation, like pins and needles. Yeah.
Might trephining help? I'm just kidding.
I imagine that would be hard to get through the IRB.
Any other questions for now? Great. As I say, we'll pick up more on the discussion.
Thank you
very, very much. Well, it's my pleasure.